Hello, my name is Laura Cole, and I'm here to present to you an evidence-based approach to improving quality of life for individuals suffering from Alzheimer's disease. A little bit of background as to why this is an important area of study is that 5.7 million Americans have been diagnosed with Alzheimer's disease currently living in the United States. We have to strive for a progressive and accurate diagnosis that could potentially save $7.9 trillion annually in medical costs associated with Alzheimer's disease and other dementias. There are also main focuses of Healthy People 2020, the Triple Aim, and the AOTA Vision 2025. Alzheimer's disease is the sixth leading cause of death in the United States, and as the baby boomer population is getting older and over the age of 65, we are focusing on seeing this number grow exponentially. So the population intervention, comparison, and outcome comes focused through individuals who are over the age of 65 and have expressed the need to improve their function or have demonstrated motivation to improve their function, focusing on typically individuals with mild to moderate dementia. The intervention that we will focus on is cognitive retraining. The idea that memory loss in individuals suffering from Alzheimer's disease is related to a change or defective method of encoding or storage of the information, not necessarily a generalization of forgetfulness. So we will be using explicit and implicit learning techniques as well as errorless and errorful learning through cognitive stimulation, an active or a passive process. Active process includes reading, puzzles, and one-on-one stimulation. And the passive stimulation focuses on things like listening to current events or watching television or audiobooks. Memory rehabilitation focuses on things such as time-task recall, allowing for improved independence with simple tasks to be improved over time, as well as identifying the way that we can focus on individualization of treatment. Reality orientation uses the compensatory techniques to improve one's orientation to not only their facility or home setting, but actual orientation to time and function as well. Now, the neuropsychological interventions utilize the sense of feeling and a healthy understanding of truly what's happening on a physiological basis, especially with changes in age. The application of this process is to allow for OTs to provide a compensatory technique to eventually decrease hospitalizations and improve quality of life. And by now I'm sure most of you have heard of the Rogers article that links occupational therapy to a decreased hospitalization and readmission rates. We will also utilize this technique to improve an individual with Alzheimer's chances of returning home and aging in place with additional education for caregivers. Not only can this program be helpful within a subacute or acute rehabilitation, it can also be helpful actually within the home as well. Clinical implications of this program are to cement occupational therapy as the profession to adequately inform clients and families, utilizing health literacy as well as identifying appropriate ways to educate individuals regarding disease prevention and progression. Focusing on the Institute for Healthcare Improvement, Triple Aim, which focuses on the improved patient satisfaction and quality for patient experience, improving the health of the overall population, and reducing healthcare costs. Healthy People 2020 also wishes to reduce morbidity as well as the costs associated with Alzheimer's disease and dementia, as well as maintaining and enhancing quality of life. And as for AOTA, Vision 2025 states that we will continue to be evidence-based practitioners. We will focus on cost-effective methods, and most importantly, we will remain client-centered. Development of clinical programming with an emphasis on cognitive retraining in outpatient settings, hospital settings, home care settings, and long-term care settings, including subacute rehab, can identify ways that we can assist with aging in place and quality of life for all individuals with Alzheimer's disease. So now that we know what we really truly want to do, now it's utilizing the evidence that we have to develop a plan. So we really need to identify what the best option for a cognitive test would be across the continuum of care. It has been identified that there are several cognitive assessments that are utilized in long-term care, short-term rehab, in the hospital setting. However, it is also necessary that we are focused on utilizing the same type of cognitive testing that a physician will use to diagnose Alzheimer's disease, so that we know baseline approach. We also need a professional understanding to utilize the uses of cognitive retraining in all settings. So not only would somebody with Alzheimer's disease be provided care within a long-term care setting, however, if they are at the hospital for an acute stay, utilizing the appropriate compensatory techniques and cognitive retraining to allow for maximum independence, possibly negating the need for a short-term rehab stay. We also would like to provide appropriate training for facility staff, family members, and individuals suffering from Alzheimer's disease to understand the disease process and understand what things that they can control and what things they can't control. We also want to focus on the fact that there is an emphasis on quality of life and quality of sustained functional independence. So not only are we focusing on truly identifying the client's goals, but we really want to make sure that they understand that what we're doing with them is to help them sustain their functional level of independence. There is limited research currently on the reversal of cognitive testing and retraining. This is focused more on truly lengthening somebody's quality of life and their functional independence. So clinical reasoning, critical thinking, and an evidence-based approach. So obviously we discussed cognitive training and the 4 approaches, including cognitive stimulation, cognitive memory rehabilitation, reality orientation, neuropsychological rehabilitation. Each of those techniques has something ingrained within it that can be helpful for an individual with Alzheimer's disease. Use of each of these techniques is appropriate in a particular situation. However, it might take a little bit of memory rehabilitation and reality orientation to maximize an individual's level of independence. So being able to identify and work appropriately utilizing these strategies will help us to develop the best plan for each individual. We also need to understand which cognitive standardized assessments are appropriate in a particular scenario, interpreting the results to develop an appropriate individualized treatment approach. Obviously, we're looking at mild and moderate dementia, so what would happen if an individual under our care changed to being within the severe category of dementia? Implementation of the evidence-based program really requires buy-in throughout the continuum of care. We really need to focus on having our physicians truly diagnose dementia and Alzheimer's disease when appropriate. I have done a little bit of research on the changes of memory and cognition, and physicians are often afraid to actually put the label of dementia or Alzheimer's disease on an individual. We need to identify the areas of concerns for the individuals and their families, include their specific areas, whether it be an individual caring for themselves with bathing and dressing, or if it's something that, a family member just wants to be able to maintain a relationship in terms of, being able to play a game or functionally participate in family events. Obviously, establishing a baseline for performance levels is a very important piece of all of this, to make sure that, there is no change or decline in function. Using collaborative goal writing exercises with the family and with the client to allow for maximum buy-in from all individuals. Obviously, we want to identify the desired outcomes working towards or achieving a certain goal. Intervention planning to address goals, utilizing appropriate techniques. Implementation of the intervention, actually providing the intervention, family present, family not present. Monitoring progress and adjusting the intervention as needed if things are not working correctly, and assessing the outcome of the intervention to determine additional steps and if the intervention is actually appropriately working. So the need for future evidence is pretty clear within this topic. Limitations on research are related to the cognitive retraining approaches. So neuropsychological retraining has been the least studied, whereas reality orientation and cognitive task retraining have been most studied. We want to use the use of appropriate standardized cognitive assessments and the development of a broader scope of practice, and additional services to be provided within the home setting to make sure that people are able to age in place. AOTA suggestions have been published within the American Journal of Occupational Therapy for area for future research, including multi-component intervention to improve or maintain ADL performance, occupation-based interventions for reducing problematic behaviors, comprehensive rehabilitation to improve ADLs, wander gardens for improving behavior and reducing falls, sensory devices worn by people with mild Alzheimer's disease to facilitate wayfinding, environmental modification without or concurrent fall reduction strategies for preventing falls, multi-component psychoeducational interventions for delayed nursing home placement, and case management by occupational therapy practitioners focused on both the client and the caregiver for promoting caregiver respite access. So those are just a couple of the main areas for future research that truly need to be implemented to allow for us to appropriately care for our loved ones with Alzheimer's disease. The future of cognitive treatments. We really have to focus on this now. We currently have a population of 5.7 million individuals with Alzheimer's disease, and that is expected to grow to 14 million by 2050. We have to identify and develop a plan for the future and how we will educate individuals. There is definitely a large gap in understanding the reverse effect of cognitive rehabilitation. However, maintenance is understood, and it's through compensatory techniques. And if we can focus more on the need for continued maintenance of cognition versus the reverse effect, which I know that most families feel that through cognitive training, their loved ones should reverse the effects of the cognitive concerns that they are having. We need to arm ourselves as clinicians to develop treatment plans that are appropriate and they incorporate cognitive programming. Developing and continuing to research the impact occupational therapy and cognitive rehabilitation have on the quality of life of individuals suffering from Alzheimer's disease. And we need to measure our success, and that's by making sure that our individuals with Alzheimer's disease and their families achieve the goals that they want to achieve. So in conclusion, there's a clear need for continued research into improving quality of life through cognitive retraining. I am lucky that I work for a large nationwide company, and they are able to assist me with development of research if needed, and they are definitely willing to improve the lives of those that we serve with Alzheimer's disease. Here are my references. I thank you very much for listening to my presentation, and I urge all of you to really take a look at the article, Higher Hospital Spending on Occupational Therapy is Associated with Lower Readmission Rates, if you haven't already. Thank you very much.